Thank you for listening to our seminars. We provide live seminar every Sunday on important medical topics. Our goal is to share our experience with all the practitioners across the globe. To encourage us, please subscribe to our channel, like it, and share it, especially with medical students, postgraduate students, and practitioners, because we don't provide just pure academics. Most of the time, we talk about how to manage a patient effectively. That is our ultimate goal, is to make the patient better using very up-to-date guidelines. Again, if you have already subscribed, thanks for subscribing to our YouTube channel. And also we do have a WhatsApp channel. Please look the link below. With that introduction, let's move on to our topic, non-invasive and invasive mechanical ventilation in status asthmaticus. We have already done 4 seminars on mechanical ventilation. Please look at the previous seminars in our YouTube channel and WhatsApp channel, please. Status asthmaticus prevalence has increased worldwide, and it is associated with significant morbidity and mortality. In recent times, there is improved outpatient management with more inhaled corticosteroids have meant less serious patients. But still, because of various reasons, we tend to see very sick patients in the ICU and also in emergency departments. The etiology of status asthmaticus is multifold. Mostly it is unknown. It could be hygiene hypothesis or IgE dependent inflammatory response. Pathogenesis we can decrease to 3 important elements. One is bronchospasm, second, inflammation, third, increased mucus production. And pathophysiology, it causes increased workup breathing and causes VQ mismatch as a result of atelectasis of the alveoli. Third, associate with adverse cardiorespiratory interactions. Clinically, they will have a shortness of breath, persistent cough, wheeze, chest tightness, and frank status asthmaticus. At that point, the patient will be in acute hypercarbic or hypoxemic or mixed respiratory failure. 90% of the time, the acute severe asthma occurs because of the chronic presentation with previous poor control. But in 10% of the time, it can be hyperacute. We call hyperacute fulminant asthma. That means onset occurs less than 3 hours. When you evaluate the patient, takes the pertain like previous intubations and ICU admissions, previous control, how well the asthma was controlled. If the patient is visiting the hospital more frequently or admitted in the hospital more frequently, poor psychological circumstances, poor response to treatments. This particular slide shows 3 groups: 1, asthma history, social history, and comorbidities. In asthma history, specifically, you look for previous severe exacerbation like intubation or ICU admissions, more than 2 hospitalizations for asthma in the past 1 year, more than 3 ED visits for asthma in the past year, more than 2 canisters of short-acting beta agonist CEs, and difficulty perceiving acute asthma exacerbation symptoms by the patient, and a lack of written asthma action plan, and currently using or recently stopped oral corticosteroids. Among the social history, and for low socioeconomic status or inner city residents, illicit drug use, major psychosocial problems. Among comorbidities, cardiovascular disease, another chronic lung disease, chronic psychiatric disease, and food allergy. Triggers can be two groups, whether specific, another one is non-specific. The specific group, upper respiratory tract infections, can trigger, that is the most common cause of asthma exacerbation, sometimes house mite, pollens, animal, aspirin, and using beta blockers can trigger acute exacerbation of asthma. Non-specific reasons like cold air, exercise, atmospheric pollutants, stress, emotion. When you examine, look at the respiratory rate, saturation on room air, suprasternal retractions often indicates severe acute asthma exacerbation, and the patient is in upright posture, cannot even lay down, or having sweating. Those are all indicates the patient is in severe asthma exacerbation. The signs such as accessory muscle use, pulsus paradoxus exceeding 25, heart rate adult more than 110, in children more than the maximal heart rate for that particular age, respiratory more than 25 to 30, in children more than the respiratory 95th percentile for that particular age, and those patients who are not able to save the word in phrases, and peak expiratory flow is less than 50% or less than 100 liters per minute, and saturation is less than 92%. These are the markers of severe asthma or status asthmatic. Initial blood gas will show respiratory alkalosis. With tiring, the carbon dioxide rises. Metabolic lactic acidosis can result from the treatment itself, like albuterol or adrenaline. They can cause beta-adrenergic stimulation that causes glycolysis and increased pyruvate and lactate production. Chest X-ray will show severe asthma, lower respiratory tract infection, or barotrauma. Always monitor potassium and MAG, especially when the patient is on continuous albuterol. The differentials to consider are the left ventricular failure, anaphylaxis, aspiration, upper airway obstruction like vocal cord dysfunction, tracheal stenosis, inhaled foreign, pulmonary embolism, hyperventilation syndrome, pneumothorax, and paradoxical motion of the vocal cords. Established treatments we already talked in our previous seminar: oxygen, titrate the saturation, titrate the oxygen to keep the saturation above 92%, and beta agonist in status asthmaticus if the child is already on continuous albuterol. If you're outside United States, one can use IV albuterol or IV salbutamol. So IV salbutamol is not available in the United States. Anticholinergic, one can use ipratropium bromide 500 microgram Q2 to 6 hourly nebulized. Corticosteroids, one should use 1 to 2 milligram per kg per day every 6 hourly. Prednisone 1 to 2 milligram per kg per day. And aminophylline we do not use in the United States, but there are lots of places outside the United States they are still using aminophylline. The dose is 6 milligram per kilogram load, followed by 0.5 milligram per kg per hour. The most important thing is you need to check the aminophylline level. You need to keep between 30 to 80 micromole per liter. Other treatments such as epinephrine. In the United States, we use subcutaneous, especially in the pre-hospital setting or during initial ED visit. The dose is 0.5 milligram. And for continuous, we use terbutaline in the United States, but outside the United States, people use adrenaline infusion. And MAC sulfate routinely given, especially in severe status asthmaticus, the dose is 50 milligram per kg over 20 minutes. And Heliox, it definitely helps to reduce the turbulent airflow when you use typically 70 to 30 or 80 to 20 or 60 to 40. And ketamine infusion definitely helps because it can cause bronchodilation. The dose is 0.5 to 2 milligram per kg per hour. And inhalation agents such as SIVO, using anesthetic machine or custom fitted ventilator, one can use to deliver. And bronchoalveolar lavage, it clears the mucus plugging, but it can transiently worsen the bronchospasm. But this seminar focused on only four things: Heliox, heated high flow nasal cannula, BiPAP, and invasive mechanical ventilation. Heliox is a low density and viscosity aid, yet available in 80-20, 70-30, and 60-40 fractions. It promotes larger, smoother gas movement in the endotracheal tube. It is already intubated in non-intubated patients through the tracheobronchial tree. It lowers the airway resistance. It lowers the workup breathing. And there are a couple of studies I want to discuss with you how the Heliox helps in patients with status asthmaticus. This study was published in 2022, the effect of albuterol with Heliox versus albuterol nebulization without Heliox in asthma exacerbation. As you can see, you'll see the response in 20 minutes and persist in 40 and 60 minutes. The forced expiratory volume has definitely improves when you use standard treatment with Heliox. That means the ability to deliver the albuterol is much better when it is combined with Heliox. And peak expiratory flow rate also showed improvement in 20, 40, and 60 minutes. So another study was published, it's a meta-analysis in 2014, Heliox-driven beta-2 agonist nebulization for children and adults with acute asthma. As you can see, when you use Heliox to deliver albuterol nebulization, the peak expiratory flow decreased in the group they used Heliox, and hospital admissions decreased in the group they used Heliox, and adverse effects nil. And so the Heliox definitely helps in delivering albuterol in patients with status asthmaticus, especially in severe ones. Second one we are going to talk about is non-invasive ventilation. This was published a few months ago in Respiratory Care. It compared three types of non-invasive ventilations in patients with status asthmaticus. As you can see, the high-flow nasal cannula for the past 5 years, the usage has been dramatically going up. On the other side, the BiPAP and CPAP incidents are decreasing. So we are going to talk about high-flow nasal cannula, usage of BiPAP. We are not going to talk about CPAP in this particular seminar. First one being heated high-flow nasal cannula. Number one, it is non-invasive, is easily usable, and being used in almost all the hospitals across the United States with increasing frequency. High-flow nasal cannula is not just a standard nasal cannula turned up to the high flow rates. High flow nasal cannula, where the gas is heated up to 37 centigrade, which is a relative humidity, and can deliver room air to 100% oxygen at flow rates up to 60 liters per minute. The flow rate and the FiO2 can be independently titrated based on a patient flow and FiO2 requirements. How does the high flow nasal cannula truly works? Number one, it's heated and humidified, improve the secretion clearance, decrease airway inflammation, and also decreases energy expenditure. It also meets inspiratory demands. What does that mean? The peak inspiratory flow at rest is about 30 to 60 liters per minute. It can reach up to 120 liters per minute in patients with acute respiratory failure. The high flow nasal cannula attempts to match up with the patient requirement. Third, it increases the functional residual capacity. For 1 centimeter of water, PEEP was increased with 10 liters per minute of flow delivered with closed mouth breathing. So it definitely improves the functional residual capacity, likely because of added PEEP. And it is very lighter. There is no big mask over the face to deliver high flow nasal cannula. Another concept I want to discuss is called oxygen dilution. Most of the clinicians know this. When you give nasal cannula oxygen 1 liter, it gives 25% FiO2. That is 4 over the 21%, which is room air. 21 plus 4 is 25%. This is called 4 to 1 rule. And when you go up on the floor to 2, it becomes 29, so on and so forth. When you reach 4, 37%. The other concept I wanted to discuss is called oxygen dilution. When you give 6 liter of 45% via nasal cannula, the patient also breathes inspiratory flows 30 to 60 liters. We just talked. Also does that using room air, which is 21%. What is the likelihood of having inspired FiO2 at the tracheal level in this particular patient? Definitely, it's not going to be 45%. It most likely is going to be closer to 21%. This concept is called oxygen dilution. The next situation, when we deliver 45% FiO2 using high flow, say 60 liters, the patient also breathes 20 liters room air. So what is the likelihood of having 45% in the trachea? Most likely yes, because the high flow ensures the FiO2 delivered goes into the tracheobronchial tree. So the high flow nasal cannula works on 5 fronts. Number 1, it meets inspiratory demands, as we discussed earlier, and decreases oxygen dilution. Third, it lighter and more compliance. It is just nasal cannula, and it increases functional residual capacity. And fifth is dead space washout. What does dead space washout means? When you take inspiration, you breathe in room air. When you expire carbon dioxide. But when you rebreathe, when you do the breathing afterwards, you tend to inspire, you inspire 1/3 of your own expired air. That means the inspired air contains not only the room air, which is 21% FiO2, and also it has carbon dioxide. But when you put on high flow nasal cannula, it causes dead space washout. So it ensures whatever the FiO2 you set. For example, if you set 45% FiO2, that's what the patient gets. Let's look at some studies. High flow nasal cannula in pediatric critical care asthma. This is a non-inferiority trial looking at high flow nasal cannula and aerosol mask delivery. As you can see, between this aerosol mask and the high flow nasal cannula, there is no significant difference over almost 24 hours. So they used progression of modified pulmonary index score, and there was no significant difference between these two groups. But the intention of this study is non-inferiority trials showing high flow nasal cannula is not bad. But when you look into the details, time on continuous alveolar was shorter in high flow nasal cannula when compared to aerosol mask delivery group. And also 24 subjects in aerosol mask group were eventually treated with high flow nasal cannula. That means the quarter of that aerosol mask group was eventually treated with high flow nasal cannula. The next one is BiPAP, bilevel positive airway pressure. This is a meta-analysis of randomized controlled trials. How non-invasive positive pressure ventilation helps children with acute asthma. There were 10 randomized controlled trials involving 558 children were included in this meta-analysis. It was published just last year. As you can see, the meta-analysis clearly shows the saturation improves with non-invasive, that BiPAP, and PaO2 clearly improves with BiPAP, so does PaCO2. Respiratory rate increases and symptom decreases, and also the length of hospital stay. Overall, the meta-analysis shows clearly the beneficial effect of BiPAP in patients with acute severe asthma in children. The advantage of non-invasive ventilation, number one, it overcomes the intrinsic PEEP from gas trapping. Thus, it reduces work of breathing. The second, it augments inspiration. This is work of breathing, increases tidal volume and minute ventilation. It can decrease the expiratory work by opposing dynamic airway compression and allowing more expiration with less gas trapping and hyperinflation. The disadvantages of BiPAP, claustrophobic, because you put the mask over the face. Lots of patients, especially children, they do not like it, and causes agitation. It can push not only into the tracheobronchial tree, it also pushes air into the stomach, causing gastric distension. If the patient do not like or agitated, it can cause patient ventilator desynchrony and increase expiratory workload, work, and hyperinflation if the patient doesn't synchronize with the BiPAP. So what are the contraindications for BiPAP? One, you cannot do in patients altered consciousness because they tend to vomit and you have airway issues. You cannot do in hemodynamic instability when there are excessive secretions and also in uncooperative way. Let's move on to the invasive mechanical ventilation. The important points to consider. One, how to assess pulmonary hyperinflation. Second, impact of ventilator settings on the severity of hyperinflation. Third, the consequences and management of hypercapnia. Dynamic hyperinflation. The gas trapping, because of inability to expel the gas, leads to dynamic hyperinflation. The dynamic hyperinflation continues until an equilibrium point is reached where the exhaled volume matches to the inspired volume. Increase in small airway caliber increases lung elastic recoil pressure, and that causes improvement in expiratory airflow. It allows inspired tidal volume to be exhaled in the available expiratory. This slide shows dynamic hyperinflation, much easier to understand. Normal respiration, you inspire and expire, come back to the baseline. There is no trapped volume at the end of expiration. But when you have an obstructive airway disease, you have trapped lung till some critical level. At that point, then equilibrium is reached, but you do have huge trapped volume in the lung. How to assess the dynamic hyperinflation? One, by plateau airway pressure. Airway pressure after transient expiratory occlusion at the end of inspiration. Inspiratory hold function is in the ventilator, one can use it. This pressure is directly proportional to the degree of hyperinflation. It should be maintained less than 30 centimeters of water. Other techniques one can use: end inspiratory lung volume, not routinely used, but it's a good predictor of complications during mechanical ventilation. And assessment of change in BP and CVP during ventilator disconnect for 1 to 2 minutes or decrease the rate to 4, and that should cause increasing MAP, mean arterial pressure, and CVP if there is a dynamic hyperinflation is present. It is easier to said than done because at that point patient will be in severe exacerbation. So disconnecting the ventilator usually not possible in those patients. What are the markers of imminent respiratory arrest? One, altered mental status. Second, paradoxical respiration, bradycardia, and quiet chest, and absence of pulsus paradoxus. So when that happens, immediately prepare to intubate this patient. Invasive ventilation is important, it is life-saving, but it is associated with major mortality, and the indications are when there is a respiratory arrest, of course you got to intubate, severe hypoxia not relieved by our conventional measures, and altered mental status, and failure to respond to the treatment. These are the reasons one should start invasive mechanical ventilation. First, intubations. So you need to be really prepared to intubate. Nowadays, very rarely we intubate asthmaticus because the morbidity mortality associated with the intubation is higher. But in case if you need to do, load with IV fluids and have inotropes ready to go. When you use endotracheal tube, use large size endotracheal tube. And use ketamine and propofol. Both of them have bronchodilatory properties. And slow hand ventilation prior to intubation, and attention to possible complications. The ventilator settings, the goal is to avoid dynamic hyperinflations and hyperventilation. Minute ventilations we like to achieve 100 ml per kg per minute, that's an adult. Child volume 6 to 8 ml per kilo. Respiratory 10 to 14 in children age appropriate. Short inspiratory time is warranted. High peak airway pressure, low plateau pressure, it decreases barotrauma. We like to have a square pattern than decelerating flow pattern. When you use pressure control mode, you can have square pattern and keep expiratory time prolonged, like 3, 4 or above. Hypercapnia usually happens after the invasive ventilation, not only because of the invasiveness, because we tend to do sedation and paralysis. The other important parameters one should think is PEEP. What kind of PEEP one should use? Traditionally, there were no PEEP was given in patients with status asthmaticus because they do have intrinsic PEEP. But the current concept has changed. The PEEP can be 60 to 80% of auto PEEP to augment distal airway emptying through splinting the airway open. This is done in non-intubated patients, 60 to 80% of the assessed intrinsic PEEP. But when the patient is intubated, we tend to keep the PEEP less than 5. Adjust the ventilatory parameters to decrease dynamic hyperinflations, but not to decrease PaCO2. In other words, the higher PaCO2s are tolerated in patients with status asthmaticus. If plateau pressure is more than 30 or cardiovascular suppression is evident, reduce the rate. If plateau pressure is less than 30 centimeter, and ventilations can be liberalized with increased respiratory rate and reduction in sedation, that will help to get rid of carbon dioxide. Hypercapnia is well tolerated, but consider bicarbonate only if the pH is less than 7.1. The treating dynamic hyperinflation is very critical in patients with status asthmaticus. Even small reduction in hyperinflations will make significant change as far as the ventilator tolerance and also outcome. After you intubate the patient, you need to keep them sedated. The drugs we use is dexmedetomidine and ketamine. These are the two commonly used drugs. Sometimes one can use propofol, and in children we have a black box warning. Dexmedetomidine advantages are it does not have a respiratory depression effect, mildly anxiolytic, and offers mild sedation. Ketamine doesn't have a respiratory depression, especially in the lower dosages. Also, it offers bronchodilation. The side effects with ketamine are bronchoria, siluria, and laryngospasm. Propofol, only in intubated patients, we do not use in a non-intubated patients, can be used along with ketamine. Not only it reduces the amount of propofol is needed, but both of them have bronchodilatory properties. Neuromuscular blocking agents can be used very sparingly. If needed, use cisatracurium, which is much better than, or rocuronium. Because of the fear of causing, not fear of causing, it will cause myopathy, especially in association with steroids we routinely give in patients with asthma. Hypercapnia. So serious adverse consequence of hypercapnia is uncommon, but it does have effect on CNS and cardiovascular system. Alternation agents may be considered, especially when the arterial pH is 7.15 or 7.2. One can use bicarbonate, but it also increases carbon dioxide. So if you have a tromethamine, that can be used for correcting respiratory acidosis without increasing carbon dioxide. Other complication is hypotension. It's not because of the intubation per se, because of we use sedation, dynamic hyperinflation, pneumothorax, arrhythmias, hypovolemia, and of course intubation per se. All these can cause hypotension, so preload and be ready with vasoactive drugs. Pneumothorax is another feared complications. It is mostly because of dynamic hyperinflation caused by status asthmaticus. Conform with the X-ray and decompress with chest tube immediately and treat hypotension often associated with pneumothorax. Myopathy is common in patients with status asthmaticus, especially after prolonged deep sedation. If you use steroids with neuromuscular blocking agents, that increases the incidence of myopathy. What are the non-conventional interventions? One is general anesthesia, second is bronchoscopy, and third is extracorporeal life support. Among inhalation anesthetic agents, one can use isoflurane, halothane, or sevoflurane. The effect should be evident within a short period of time. Continued administration in the absence of clinically meaningful reduction in hyperinflation or hypercapnia is unwarranted. But one should remember the side effect of these inhalation anesthetics is hemodynamic instability. Again, you have to watch both hemodynamics as well as the improvement in dynamic hyperinflation. Finally, bronchoscopic removal of impacted mucus. As we know, this asthma has three components: bronchospasm, inflammation, and mucus production. The treatment discussed: improve the bronchospasm with the beta-adrenergic agonists and anticholinergics, and inflammation by steroids. And the mucus production, none of these medications help or change the mucus production that happens in patients with status asthmaticus. So bronchoalveolar lavage with or without N-acetyl system inserted directly into the airway can help to remove the mucus, the bronchial tree. If none of them work, then finally we need to start VV-ECMO with ultra-protective ventilation strategies for the lung. The survival rate is not that bad, about 83%. So in a nutshell, this algorithm explains the whole seminar. And the patient is admitted with hypercapnic or hypoxemic or diaphragmatic fatigue. We first treat with BiPAP, IPAP of 10, EPAP of 5, it can go all the way up to 10 and 20. If the patient is not doing well, and intubate the patient. And put the patient on the mechanical ventilation with the following setting. I really like the assist control, FiO to 100%, and the respirators based on the age of the patient. The PEEP, keep it 5 or below, tidal volume, shoot for 68 ml per kilo, ideal body weight, and keep the plateau pressures less than 30. The patient was admitted in inpatient if the patient has altered mental status or is not tolerating, not doing well with the conventional treatment. Again, ended up getting intubated and finally in ICU. So if the patient is doing well or not doing well, and consider bronchoscopy as we discussed with N-acetyl system, or use anesthetic agents, and finally ECMO. And there is another group when there is worsening dynamic hyperinflation because polytrauma or barotrauma, they decrease eye time and temporarily disconnect the patient from the ventilator, do the mechanical chest compression. Personally, I have never done it, but there have been reports using this particular maneuver to decrease the dynamic hyperinflation. With this one, we conclude this seminar on invasive and non-invasive ventilation in status asthmaticus. Please leave your comments in the comment section, and if you like it, please like it and share it with others, and subscribe to our channel to help us grow and serve better. Thank you so much for listening.